with that, with meeting so duly started, like to start with the adoption of the minutes from the March 26th, 2026 meeting. Do I have a motion to approve?
So moved.
Second,
Second.
all in favor? Aye.
Aye.
Okay, the minutes are adopted. And with that, we'll go to the first action item, which is authorizing the submission of a resolution to the Board of Directors of New York City Health and Hospitals to authorize the Executive Director of MetroPlusHealth Plan, Inc. to execute best interest contract extensions with Prager Creative LLC and Bellwether LLC for outsourced strategic creative marketing, media buying, digital marketing, and social media marketing in the amount of $25 million, a new total contract authority amount of $60 million, inclusive of a 10% contingency. And with that,
MetroPlus outsources strategic creative marketing, media buying, digital marketing, and social media marketing services to support member growth, retention, and brand awareness initiatives. MetroPlus has utilized outsourced marketing and media services since 2007. And since 2021, these services have been provided through two of our vendors, Bellwether LLC and Prager Creative LLC. The original contracts with Bellwether and Prager for these services were competitively procured through an RFP process in 2021, and the current contracts expire in August of 2026. MetroPlus is requesting an increase in authority in the amount of $25 million to support two-year best interest extensions, inclusive of a 10% contingency. We are requesting approval of a best interest extension to continue utilizing these vendors to ensure our continuity of services, maintain strategic momentum, and avoid disruption to ongoing marketing and member engagement initiatives. We have current campaigns underway and member retention efforts serving as a primary organizational focus, and MetroPlus has determined that it is our best to maintain ongoing services with our current vendors. Additionally, MetroPlus evaluated our current vendors' pricing against market benchmarks and determined that the rates provided by both vendors remain competitive, reasonable, and aligned with prevailing market pricing. Both vendors have consistently delivered strong outcomes in driving increased brand consideration, strengthening acquisition performance, and producing measurable results. This is evidenced by sustained growth in brand consideration over time, steady call volumes with significantly improving lead quality, and a robust digital ROI of approximately 3-to-1 across a channel that represents 60% of the overall marketing budget. The increased spending authority request is broken out as follows. Our original authority, which was for a 5-year term from 2021 to 2026, was in the amount of $20 million. At that time, our average annual spend was anticipated to be about $4 million per year. In late 2023, we were getting ready for increased and expansion of marketing strategy for Gold, Medicare, and ethnic marketing. So we came to the MetroPlus board and the H&H board in December of 2023 to ask for an additional authorization increase of $15 million to bring the new spending authority to $35 million.
Okay. Just to interject, and that kind of brought our baseline spending up to just under $10 million a year. So that's the current baseline we're working from, 10 million. And, you know, Tally's going to go into the details of why we're looking to increase that a little bit more. But I just wanted to pause to have everybody absorb that point. Because when you just look at the chart, and this chart's my fault, you know, because I like to get the numbers out there. It looks like we go from 4 to 7 to Y12 and a half. And the idea here is that we started off very low, but we've kind of expanded and done more and more, and we've kind of increased the marketing aspects, and it's had very beneficial, as you can see from some of the numbers. But so I just wanted to interject for the board to kind of alleviate any kind of, you know, just looking, because I have a habit of looking at a chart, seeing the numbers and saying, wait, why did that go up 82.3%? No, it did, but that's how my mind works. So I just want to just interrupt for a second, just to interject that point. So
Thank you for
Advantage that.
that makes it a little more clear. And also, it was a progression, right? We began when we went originally in 2021, we had a different marketing strategy at Metro Plus, and over the years we've expanded on that with given what is going on with the different lines of business and whatnot. So it has progressively increased as well. And the spend has increased to as our marketing campaigns have expanded as we've brought in ethnic marketing, as we've increased for the gold line of business and for Medicare. Our current ask is to remain with these two vendors for 2 years as do a best interest extension with them. The amount is 25 million. That includes a 10% contingency. We factored in CPI costs because one of the vendors we purchase most of our media from, and while we have a range of fees that we've built into our contracts, they can increase depending on CPI. And also we wanted to include a slight buffer in case we continue to increase our campaigns and need to increase our marketing strategy.
Hi, this is Juliana. Can you all hear me?
Yeah.
I can't exactly put names to faces for everyone, so I could see who was speaking there. The gentleman who was speaking before was.
Right.
Hi.
He's our chair of the
Um,
finance committee and
hi.
vice chair.
Okay, thank you for that. You mentioned that we could see the ROI on the slide, or at least it sounded like you mentioned that, and I don't see that on the slides. Was it on these slides?
The previous slide.
Yes.
The one that said the 3-to-1?
Correct.
Is the 3-to-1 ROI across the spend across all of the years that we're looking at there in the next slide?
Yes, it's across all the years.
Okay, understood. And what in terms of how we're understanding ROI in this sense, what does that mean? How are you
It,
calculating that? How do you get to the 3-to-1?
So the way that the department calculates it is they calculated amongst how we what the brand awareness and what the campaigns what they produce for us over time. We measure it through our call volume, through retention efforts, through leads that we get. So it's across sort of the whole marketing division, and they bring it in to sort of apply it to the how they're laying out their strategic marketing plans for the years.
Juliana, so each campaign that we run, at least under the current leadership that's been here for a few years, we have either a dedicated phone number or a QR code or a way to identify the campaign.
I
So
see.
that we have a way to track whether a certain campaign is actually working for us. So then we're looking at, as Tali said, we're looking to see for each campaign how many inquiries that we have, and then we see what we updated, what the disposition is as we updated in the system, and then relatively recently, we started looking all the way to see whether they in fact became an active member. So
Hmm.
there's a tracking, and this is how we know which campaigns work better and which campaigns do not work for us. So the 3-to-1 is an average, but it's an accumulation of all of those trackings together.
Okay, thanks, Tali. That's very helpful.
The request is for a 2-year best interest contract extension with Traeger Creative and Bellwether. Our increased contract authority is for 25 million. This is inclusive of a 10%.
And I think
We'll need to go to the H&H board as well for additional approval.
as far as resources in the budget, this is currently already in the budget, so it's accounted for. So it wouldn't cause any type of increase there. So this was kind of forecasted and part of the projections back, for a while. Are there any other questions? Not, I'd like to ask for a motion to approve. Any second?
Second.
All in favor, aye?
Aye.
All right, so the motion is approved. And with that, I'll turn it over to Valencia.
Sorry, I had to take off mute. Good afternoon, everyone. This is requesting the authorization of the Executive Director of MetroPlusHealth Plan to execute a best interest contract with Sutherland Healthcare Solutions to support the Gold Signature Experience for a total amount not to exceed 4.5 million, which includes a 10% contingency for 1 year contract term with 2 1-year renewal options. Staff is going to walk through this piece.
Okay. Just for everyone's knowledge, Laura Santilli would have been here, but she's at an conference, so I'm filling in for her.
Well, introduce yourself too.
Hi, I'm Tali Legger. I'm the Senior Director of Procurement here at Metro. So MetroPlus is seeking a best interest contract with Sutherland Healthcare Solutions to support the Gold Signature experience. Sutherland will provide high-touch, personalized membership support to MetroPlus's Gold and Gold Care lines of business, which provides coverage to New York City employees. The personalized support will span across benefits, claims, providers, and end-to-end healthcare navigation. This partnership is designed to deliver a differentiated member experience that is responsive, accessible, and easy to navigate. MetroPlus is seeking approval for a 1-year contract with 2 1-year renewal options for a total contract authority of 4.5 million over the 3-year term. The authority includes a 10% annual contingency. MetroPlus conducted a request for information in late 2024 to identify opportunities to enhance the Gold member experience. Based on those RFI insights, MetroPlus launched a pilot with Sutherland to deliver enhanced personalized support to a subset of new Gold members during their first 90 days of enrollment. The pilot delivered strong results, demonstrating improved member engagement, satisfaction, and the value of high-touch support. We're now seeking to scale this model and establish a consistent, differentiated signature member experience. Gold and Gold Care lines of business are critical to the growth and future of MetroPlus. They are the city employees' healthcare option. And so we want to maintain the continuity of services and expand on this pilot and preserve the institutional knowledge and training. We're not anticipating issuing a new procurement at this time, but we want to monitor the vendor and continue to see that they continue to demonstrate strong performance, especially as we expand on this initiative. The annual renewal option will allow us for continued assessment of performance and competitiveness, and we will only exercise them if the services continue to deliver measurable member benefits. We spoke about this at the committee yesterday, and we will do an assessment before we exercise the renewal options to determine that this is something that we want to continue to pursue. This 1 year does give us the opportunity to really expand on the services and take the pilot, which was for only a certain subset of members and only in their first 90 days, to really see how this works for their full experience. So the scope of services for this is deliver a high-touch, personalized support experience that simplifies and enhances the Gold and Gold Care member journey. We want to create a proactive member outreach and benefit education, provide personalized assistance across benefits, claims, provider access, and healthcare services. And we want to enable streamlined access to information, resources, and support through a seamless member experience. We're going to coordinate member issue resolution across internal teams, vendors, and provider partners, and ensure timely end-to-end resolution on all member inquiries and service concerns. Our request is seeking a 1-year contract with 2 1-year options to renew. The total spending authority request is 4.5 million over the full 3 years. The authority includes a 10% annual contingency. We want to make sure that we have the contingency set up in order if we need to address any potential changes in member volumes and service needs.
And, I would just add to this that, the Gold program is a very important program for the city, not just for Metro Plus, but for the city to be successful. So this is a really important investment, not just on our own behalf, but it can have significant return for the city as well. So I think this is a very important initiative to try and see how it works. And if it can give us higher retention and then expand our membership and into the city health benefit program more, it could be very important for, as I said, not just for us, but for the city as well. With that, if any questions? If there are no questions, I'd ask for a motion to approve. Second.
Second.
All in favor?
Aye.
And with that, it's approved, and we'll go to the first update. Great.
So I'll cover this one. So we here at the plan, we are looking to make an investment into our community sponsorship initiative. Given the changes that are coming down from the federal government and the communities that we serve, we need to meet our communities where they are with the items that they are in need for. Most importantly, food, diapers, other types of necessities. So we want to meet them where they are in their space, provide them, the support that they need, especially now that SNAP has been, affecting so many people within our community. And as we explore these partnerships, we need to allocate $2 million for the remainder of the year to support this initiative. And this funding is coming from non-Medicaid dollars through our budget, and we wanted to highlight for the board some of the first level of action that we are taking to support our overall population. This will lead to better retention, better engagement with our members, potentially new acquisition as well. But there will be, ideally, there will be significant positive brand exposure, but most importantly, helping our members where they are and general community support during this beginning of a very difficult time in their existence. Go ahead, Valencia.
No, I think that's a great idea, but I'm just wondering, how do you identify those in need? I mean, the city is so vast and there's so many enrollees. How will you discern that?
There have been discussions on partnerships with varying entities. We've had discussions with our partners, with the city. There's H&H opportunities for us to collaborate and partner with them. Also with our community CBOs and navigator agencies. So there are a number of tentacles that we are exploring on how best to meet them. But we know our most vulnerable population and most vulnerable areas in our geographic footprint, and they are coming to the top as priority spaces for us to go and outreach to the community.
Great idea.
I don't think we're anticipating like an income verification process or anything like that. No, I mean, I think it's going to be a program run through one of our partners, and they'll be distributing it, and then the people who come and show up for it, will be given it. But
And it's not a resolution because we don't have signed contract yet. This is more an intent that we're sharing with the board because it's a meaningful amount of money for us. So just to make sure that the board is comfortable with the intent, and then once we have actual contracts, if they reach the level that requires board approval, obviously it will come back in a more concrete format.
Yeah, with that, we can.
Yes.
Hey, good afternoon, everyone. Raven Solon, Chief Compliance and Regulatory Officer at MetroPlus. We wanted to give the board some updates, particularly as it relates to 2026 New York State budget and legislative actions. That the budget actually passed in late May, almost 2 months after it was initially due. But we did see some very impactful items out of this. The first and largest, to give you the headline, is that Medicaid has been carved out of the New York State independent dispute resolution process. So for those who might not have as much familiarity yet, the IDR process is a tool to resolve payment disputes between health plans and out-of-network providers. And in 2023, Medicaid was carved into this process where, despite the fact that it had been previously exempt because there are set Medicaid fee schedules, and this caused a dramatic increase across the entire state, not just for MetroPlus, in IDR volume and expenditures. We were able to run some numbers and identify that, you know, there had been more than $5 million in just Medicaid for just MetroPlus paid out on IDR cases in, you know, a very small window of time. It took about 2 years of advocacy, but we did succeed in getting Medicaid carved out. That is the great news, the exciting news. We're expecting to see obviously reduced IDR case volume. We hope. I'm going to get to that. But certainly reduction in the payout costs. As a reminder, the IDR process is established so that there's only a choice between what the plan paid and the provider's billed charges. So whatever billed charges is, if they win the IDR, that's the payment. Unfortunately, other reforms that we were seeking on the commercial side, such as changing that framework, changing the database and benchmark that is established for determining the validity of a payment, setting stricter parameters on timely filing of these kinds of complaints. None of those were passed by the legislature in the budget as it relates to any of our commercial lines of business, which includes the essential plan. They did take all of those reforms into account for the Empire Plan, which is the state's employee plan, and they essentially intend to let that go with all of the reforms embedded for 4 years and then come back with an analysis. But we're going to continue to advocate, especially as it relates to the essential plan, especially 3 and 4, which are essentially a Medicaid-like population that, you know, has the potential for the same risk. Okay, and another major one is, you guys remember us talking about the MCO tax, and it was a big way to help fund healthcare in New York State. And then the federal government determined that New York State's program did not meet federal requirements in order to allow the MCO tax to continue through past the end of 2026. In this budget, the legislature has authorized DOH to pursue an approval from CMS that we will change the MCO tax program to meet the federal requirements. And so that will then become a uniform tax across all plans, all lines of businesses, with the exception of Medicare. Obviously, New York State can't tax Medicare dollars. And at a tax rate of 0.35%. And that the expectation is that will meet the federal standards for uniformity, and we will be allowed to essentially grandfather that in and continue the tax. And it has, you know, the potential to fund quite a bit of activity healthcare-wise in New York State, so that is a very big deal. On the Medicaid front, there are two large changes. One is that undocumented members over the age of 65 who have been carved into Medicaid managed care, effective 1/1/27, they will be carved back out to fee-for-service. It is our understanding that this is happening as a result of HR1 related changes and new definitions from CMS on who can be considered to be receiving Medicaid, and we expect to see more changes like this. We currently, you know, anticipate a couple thousand people will be affected by this change when it goes into effect on January 1st. And school-based health centers, which you might not have ever heard us really talk about in this board meeting before, but as Kathy and I were discussing earlier, I've been working on it for about a decade, and it's been floating around at the state for well over 20 years, and it has finally had a ultimate resolution that it will not be carved into managed care. It will stay in the fee-for-service realm. we have been implementing and stopping for at least 6 years in the most recent iteration. So this is, operationally a very big deal for us to finally have some level footing and all the implementation activities that it will make a difference for. Next slide, Angela. Yep. And I'll hand over to Lauren.
Any questions? If not, Lauren? Sorry.
No.
Good afternoon, everyone. Hi, good afternoon, everyone. You go to the next slide, Ange. So, just for everyone's point of view, the state fiscal year runs April to March every year. So we saw our first peak at the 2027 state fiscal year Medicaid rates, region-wide and specific for MetroPlus. So overall, the rate has a 0.5% increase, going into a time where membership will be churning at the highest I've seen it in my career. But as you compare that to the forecast, that is 3 points behind forecast. The state did note that they increased the actuarial range from the low to the midpoint, and achieving that was a 2.4% base rate trend, which is extraordinarily low. Typically, we have a historical average of about 6%. Through Q1, we are running slightly favorable at 4.5, but 2.4 in the next state fiscal year is extraordinarily low. We also saw a decline in our overall risk scores. Now, we did have a flat acuity going into our forecast, but our risk scores did drop about 1.9% due to a methodology shift within our region. I will talk about that at a later slide. And then for Medicaid, we have been tracking our enrollment versus forecast. We're about 2.5% against target. Not wildly variable, but it is due to the number of recertifications, lower growth acquisition from just having a stable base population at the overall Medicaid state level. So overall revenue impact for the Medicaid plan for 2026 is a $103.8 million change. Next slide.
That's a compared to forecast. What about compared to prior year or prior period?
Last year, we had a significant increase in our rates. We took about 8 to 9% increase on our Medicaid population. And then going into this year, through the rate setting is done at the state level, that was 0.5%. I can give you I can follow up with how we ended 25 versus forecast expectations. That's not handy at the moment.
Yeah, I'm just interested in how we are now compared to how we are same period in 25.
Sure.
Yeah. I hear we're
So,
below forecast.
yeah, so last year, the state did a lot of catching up for what we perceived as insufficient rates the two or even 3 years before. So last year, in terms of the increase in the premium, was an outlier. I do not remember when was the last time that we saw a 9%
Right,
increase.
it's typically on average between 2 and 3%, except for last fiscal year, which was the catch up, and that was about 8.9. The state has historically set rates at the lowest end of the actuarial range, and that essentially caught up last year. Now, anticipation into this state fiscal year was to have a stronger increase than what was received, because of the acuity of the overall population and the leavers versus stayers. And they were able to, reduce that by just adjusting the base trend rate to 2.4%. That's fairly unrealistic in any of our product lines that we've ever seen. Even right now, we're running at 4.5%.
Right.
So indication for the future is that we'll continue to creep back to the 6% that we we have in our forecast today.
Yeah, it's unfortunate we discussed this
Mhm.
before, but Juliana, you were not privy to those conversations previously. The way the state actuaries calculate the trend is a complete black box to us. And so they come out with those rates, and they surprise us, usually in a negative way. Last year, again, was an exception that we were surprised very positively. But usually, the trend that we see, that we experience, and that we submit to the state, by the way, on a quarterly basis through our regulatory required reporting, is is showing a much stronger trend than the trend that they gave in the rates. So we don't, again, it's a black box. We do not understand how they arrived to those rates. We believe that our forecast was absolutely reasonable on what the actuality has been last year and continues to be this year. And I think in general, the industry as a whole was surprised by this trend. And then, as you see on the slide, we were further. So this is from the state, and then obviously the rate is impacted by how we're performing on risk. And we had another unpleasant surprise there. So we have a compounded impact, a much lower trend from the state that I think is unjustified, plus how we performed on risk compared to the rest of the industry, which impacted us negatively. That combo ultimately resulted in a 0.5%, when in reality, we're seeing 4.5% increase. So there's a pretty significant delta here between what we're getting in premium and what our experience is.
Talia, I'm sorry, was somebody else speaking?
So I just wanted to note the way that New York State does set the Medicaid rates is at the regional level. So it's not the same way as the ACA program where we bid our own experience and our own actuarial attestation. It is a collection of all plans together, and they have their own actuarial team that then goes into their rate setting mode and comes out with a rate regionally for all of New York City, upstate, and elsewhere.
So Talia, I was going to ask the question regarding the risk scores. You said that the acuity was flat, but it showed that a risk decline. Was there not documented the risk level? Because that's sort of straightforward. If you have the claims, you have the population.
So, Angela, can you just advance just 2 slides and then I'll come back to it?
Yeah, we'll show the
Okay.
reasons.
Yeah. So
Okay.
here on this slide, if you just take a peek at those last 2 lines of the chart. So on the very last line, you'll notice that United picked up about 10.5%. Where we see our relative risk score as a Medicaid plan comes out with the Medicaid rates. There is not a transparent process in advance that gives us any peek into the window on how they're viewing us. But during this last state fiscal year, the national carrier here went and petitioned the state for a change to the CRG methodology, where they now have a HCBS children add-on factor. For both children and SSI, these 2 plans pulled 25% increases to the risk score. And because it's a net neutral event here, their increase caused our decrease. So we overall took a 1.9% decrease because we did not have that same population receiving those HCBS services with that experience. And by that fact alone, we came down and they came up by 25% in those 2 rate cells. So on average, now we're hit across the board because it's the regional rate that's set by the actuaries, then multiplied by this acuity score that then took another 1.9% of revenue away from the plan. So, I mean, active discussions on how we can try and mitigate this with other strategy, but there was unfortunately no foresight that this was going to be occurring as the state did not communicate a methodology change until the rates came out in April of 2026 for April of 2026. We set our forecast in October of 25.
So is any of this coding related?
This is documentation of the population's acuity. So they were able to, I don't know what discussions they had, but they were able to say that, you know, for these diagnoses, they're now triple weighted or what have you. And they just went with
The short answer is yes. That's the short answer. The longer answer is the numbers speak for themselves. We were affected more adversely than others. Obviously, that doesn't make us happy at all. And you see, it's not just United. Molina did pretty well for themselves. So how come we were caught so unprepared? But we were. So at this point, and this will be a clear follow-up from us to the board is what exactly happened with the coding? What was captured? What happened? Why are we so behind? Why are we more behind than others? That's we do not. We're working on it. We don't have a clear answer today.
So, sorry, just to clarify, it's not that we think that actual risk in the population went down. It's that we think we're not capturing the actual risk of the population that we care for.
So it's really the methodology.
Yeah.
It's ultimately how it's captured.
Creative coding too.
Right.
And does the state give us guidance about what is allowed to be high acuity and what is not, or do we determine that? And do all the plans follow the same rules or different?
So the specific algorithm is not socialized.
Right, so New York is an outlier. They are known nationally for being an outlier. Every other state basically generates a document that says this is how we got to our numbers and our rates. New York State does not do that. So when we say black box, we mean black box. We don't know how they added up, what they put in, what their algorithm consists of.
And we don't know how, like, if they said like schizophrenia is
Well,
high
here,
acuity and
the
depression is not.
it is the collection of your overall population, but New York State uses a CRG methodology developed by John Billings a million years ago. Every other state in the country uses HCCs. It's a standard Medicare methodology, and the guidance there is much more robust. So they can, the state has the ability to tweak their own model in a way that they, you know, see fit and forth. But ultimately, your CRG risk score is based on your experience, documentation of your population, and some things are more acute than chronic, and that weight matters, you know, depending on where you are. We were the most acute HARP in the region for about 3 years running. We had a very strong social determinant of health strategy that kept us there as other payers are trying to understand and catch up. That was, you know, what we were experiencing there. But on the Medicaid front, they don't issue in advance the underlying methodology. You sort of see it 3 layers up.
So
But it's very hard to believe.
Yeah, but there are some commonalities, right? I mean, I know that they may not define it, but there are some things we know far as the coding and then the records of things that you pull that will give you a higher risk score. That's pretty standard. Yeah.
Just
Okay.
intuitively, I think it's hard to believe, given your network, that you have a less.
Exactly.
Exactly. The Medicaid
Exactly.
population.
And then the change in United is just so.
But you can see the scores. They
Right.
still lost money even with scores higher than us. So you see people who had a negative change even with a higher score because there's these underlying things, right? And that, you know, arrangement.
Not to sidetrack, but when work requirements come in 27, it's going to be very interesting, this issue of how acuity is determined and risk, right? In terms of who's going to get kicked off or how you're going to have to prove who's going to get to stay or not.
That's right.
But all of that to say, you're right, Valencia. We know that the number of diagnoses, right? That's a good proxy for us. And there are some proxies. This was a more meaningful change. Because we're still looking into it, we can't comment whether we should have anticipated this or it was really an unforeseen miss. It's probably somewhere in between, frankly. I think right now the most important portion is to understand what can we see from what others have done, right, in the presence of the black box, and how can we catch up?
Mhm.
Well, if I understand correctly, the the main issue here, one of the main issues here that is identified is that United and Molina caught up. And because it's a zero-sum game, that means by default you're going to have to drop.
You're
Did
right.
I understand that right?
Yes.
So it sounded like we were doing well, they weren't doing something, they caught up. So by default, even if everything else were going well, we would have to go down.
Right.
Mhm.
Yes. So yes, we're competing against each other. You're right. So we can never, I mean, it's true for stars, it's true for HEDIS, it's true for everything. You can never say, well, look at me, I'm doing so well. I even improved, because we certainly had many years where we improved, but we still fell in the ranking because we did not improve as much as others. It's the same thing here.
Seems like as everyone else gets higher, we can go lower when you look at the stars. So
Right.
it seems similar.
Sorry, that's because we consider that high acuity population limited? So if United takes more of it, we have less of it?
No, it's literally a numbers approach. It has nothing in reality.
Yeah.
It really doesn't have much to do with actual fluctuation in acuity. It has everything to do with how the coding is being captured. So you can have the most acute population in the region. If your providers and you are not capturing it to the nth degree, you will appear in data as if you have a healthy population. So the whole point is to capture the complexity and the morbidity of your population in your coding.
And United is expert at doing this, and they have gotten in trouble.
Experts. Yes.
On the care side.
Exactly.
But they are actively in trouble at the federal level about it.
Oh, they are.
I don't understand why if United went, like Juliana was suggesting, if United went up, that someone else has to necessarily go down.
Right.
Yeah. It's a pie. You only have
Like
100
a-
pieces to give out, and it's
Yeah.
given out based on your most acute. So if you were last year, you got 98 pieces. This year, you can get 97 pieces, but there's only 100, so someone's getting gypped.
It's grading on a curve, right?
Right.
So it doesn't matter if I wrote an A paper, if you were just grading me, I can't have an A because you already gave out the 3 A's you were allocated. That's exactly, I'm having law school flashbacks. But yeah, I mean, that's basically what it comes down to. They gave their A's to United and Molina.
Got it.
And so now we're B's and C's no matter what the actual quality of our work is.
Weird. Thank you.
But it just goes back to, yes, it's important, obviously, to provide care to patients. That's a given, but it's also important to capture it and document it. Otherwise, right, it's not, you don't get credit for it.
Right.
You need me to go back up?
Oh, yeah.
Yeah.
I'll just touch on the, I think there's one more.
Yeah, there is. I wasn't sure if you would.
Oh, wait, we did.
Yeah, so it's hard.
So, just gonna comment on the, HARP line of business. This line of business covers just over 10,000 lives here at the plan. There was an overall rate reduction of 0.8%, slightly deviated to our forecast, which was a 1.4% reduction. Again, we did see our risk scores decline in this line of business, though going into the forecast, we had a flat acuity assumption. Here again, we see low base rate trends of 2.8%, though we did have a 2% forecast number going in. We've seen the HARP line of business with some volatility happening now. So where the overall enrollment has dropped 1.7%, we are keeping an eye on it. And in terms of how we're dealing with the retention on this HARP line of business, it is focused with our medical management team so that it doesn't become an unstable financial picture. And our revenue impact overall for this line of business is 9.2 million. This is here. And then the SNP line of business did see a small rate increase of 1.3%, again, but that is a reduction over forecast. We are seeing, again, a unanticipated membership decline here of an unwind for dual eligibles. And we are seeing a shift towards our homeless member mix population. So we are converting members that are identifying as homeless into the right tier and product to support their healthcare needs. The revenue impact on this line of business is about $18.8 million. Next slide. And for Q1, last quarter of state fiscal year, with the inflated rates and slightly better than anticipated trend, running a 91.9% overall MLR, MetroPlus runs a mean ALR or administrative loss ratio at 6.4%. Operating margin, including prior period adjustments with for MCO tax, is about 2.8%. And we are seeing, we're monitoring our essential plan. We saw a nice growth in Q1 for that population, and overall, with membership being at the forefront, monitoring that as we go through the back end of this year.
I mean, I'll just say, for everyone who has experience with the admin, I mean, this is a ridiculously low admin. Yeah. It's almost unreal. Only obviously it's real. We trust our numbers, but this is bound to shift. It's absolutely bound to shift, because I don't think that any plan, certainly with the complexity that our plan has, can operate long term on a 6.4%. Just as a reference point, a lot of the commercial plans operate on a 12 and 13% admin rate. And then companies similar to us operate in the 9, 10, 11 range. And even we usually operate in the 7 and 8. So this is particularly low and bound to increase. Some of it is just, delays, vacancies, et cetera. It is bound to increase. The medical loss ratio is healthy. Very a little too healthy, also indicating the trend that we are seeing. So as the administrative expense will catch up, because it needs to, operating all of this complexity, we will see the results obviously declining in the operating income. So we had a strong first quarter, and this is great. But we are expecting a decline from here towards the other quarters of the year.
And just one other thing is that we are seeing a number of pass-throughs that are coming through from the state to support distressed hospitals, health and hospital safety net dollars, MCO tax money. So there is over $1 billion that is running through this organization for those state initiatives known as directed payments. Oh, membership. Okay. So as I just mentioned, membership is on the decline. As we know, as we forecasted, we will be seeing the members continue to decline through the back end of this year. But again, 2% to forecast. So, monitoring, but essentially there. And we do anticipate this to push down to about 638,000 lives by the end of this year. Next slide. And,
I would find it helpful, and you might have it somewhere else, to see what the forecast line is. If you go back to that other slide for a quick second. Is it there? I don't think I saw it.
Yeah.
Do you see what I mean? I see the comparison to prior year. In this case, I'm asking for the forecast. Last time I was asking for the prior year. Do you see what I mean?
Sure.
You're right, Juliana. We are running about 2% or over.
2%.
About 2% right now behind forecast. So yes, we are seeing more losses than we forecasted in the Medicaid line of business and the CHIP line of business. Those, I mean, we see small declines in others, but those are the main contributors right now for the delta. But I think it's a good suggestion. We should have a line with the forecast, so it's clear where we are.
Next slide. This slide just gives you the view of our stability to market share in the current period. So for the Medicaid managed care line, you can see is holding at 15.8% as compared to 15.9%, where we ended the 2025 calendar year. The CHIP line of business had a peak in 24. It essentially is still stable to the 25 number, but when we think about the overall and where we are to forecast, that's where we're seeing a bit of a deviation. And again, partnership and care, small book of business, but there's only one of 3 in the city. So we are holding our market share there as well. And then on Medicare and long term, we're essentially next. Oh, obviously.
So the reason I'm presenting this is our deputy CEO just left last week. He was running retention, so temporarily I'm overseeing retention directly only because it is so absolutely critical for the company and obviously for our members. So I think all of the headwinds. What I will say that the newest update is the continuous enrollment. So the continuous enrollment for kids 0 to 6 went into effect, about a year and a half ago?
Correct.
And with the new administration and HR1, it was clear that continuous enrollment will not be allowed any longer. The original plan was to discontinue this continuous enrollment the end of March of 2027. We are assuming that there is significant pressure from the federal government on New York State government, and because of that, New York State government changed the date of discontinuing the continuous enrollment to next month instead of next year. So as of July 1st, literally in a couple of weeks, that continuous enrollment for 0 to 6 will stop. So a few things. A, it means more volume for our staff, right? Because suddenly you also have to recertify all of the kids, and we have a lot between 0 and 6. And also confusion for the parents, right? We just educated them that you do not need to worry about recertifying your kids. And now there's a switcheroo, and now they have to go back to recertifying. And we know it is difficult, regardless of how much communication is happening, for this population to catch on quickly because it's complex. None of this is intuitive. So definitely a meaningful headwind. I think the other headwinds are well known at this point. The only new data point here is we knew that EP5 is going away again. July 1st seems to be a pretty ominous day. For this year, we got the list from the state of New York, and now we know how many members will lose the EP5 coverage for MetroPlus, and it's a little over 31,000 members who will lose their coverage as of July 1st. The state indicated in the list that they had sent us what potential lines of business these individuals can qualify for. So some of them, right, circumstances change. So some of them can qualify now for Medicaid. Some of them can qualify for other levels of EP. Some of them will qualify for an employer coverage. But the absolute majority, based on the state's list, will qualify for QHP. And we all know that the current QHP premiums without the subsidies are extremely, extremely high, and for the most part are not affordable. So it is a huge concern. I mentioned at one of the committees this week that we are looking at this population. Obviously, we're communicating. You should be checking in with us or with the state on what you could be eligible for. Although once they realize they're eligible for QHP with premiums approaching $1,000, it's not going to be very palatable compared to $0 that they're paying right now, right? And we're talking a massive change. Nevertheless, what we are doing right now is identifying people who are receiving current treatment for serious conditions. Imagine that you get cancer treatment and suddenly July 1st, you don't have coverage. Imagine that you're taking HIV meds, right? And you may be in remission. Well, suddenly you don't have access. So we identified a few thousand people as very high risk in this group of 31,000. And we will be working closely with them to see how we can support them with finding whatever it is that's available. Obviously, we cannot create options for them, but at least we can do more hand holding as they identify whatever options that exist in New York City. Juliana, this is to your point. So as we talk about where we are, we're a little over 2% in deficit compared to our membership forecast. So it is, like we said too many times today already, a zero-sum game. Essentially, there are really no more buses coming from Texas at this point. So really, it's the point is hold on to your members, help them stay covered so they can access the services. And this is why retention is always critical for a plan, but even more so nowadays. Slide. So you're seeing some fluctuation here with our research success. There are multiple factors that impact how successful we are. Some of it, the type of population that we have to recertify that month. The ratios between the subpopulations changes. Part of it is the volume. There are just certain months that are more popular for people to enroll. And so if those were more popular months to enroll, those are also more popular months than to recertify. And so we're seeing fluctuation in the number of people that we need to recertify. And sometimes that fluctuation prohibits us from doing the full massive outreach that we do for each member to try and save them. What's the next slide? You see here we had a slight peak in disenrollment. Lila can elaborate on what happened in those months, and now we have stabilized. You wanna comment on?
Yeah, sure. It's just the beginning of the new year. We usually see plan changes and people who are either voluntarily leaving. And so we saw certain lines of businesses where we saw more activity leaving. So you saw that spike, but we are starting to stabilize in April and May. It's still not where we want it to be. We wanted to obviously get it lower than that. So we are bringing in additional temps to sort of target our involuntary disenrollments that are easier wins for us to bring back on to. So a lot of our members don't realize they're going to be involuntary disenrolled because of a clerical issue that happened. So our team's going to go in and address that, and then also try to understand underlying drivers for causing voluntary disenrollments and trying to mitigate that as well. We're working with our providers very closely, both on a retention overall standpoint, recertification and disenrollments. I don't know, Tally, if you want to talk about that, but we have assigned key operational executives to tier 1 providers that have a large number of members attributed to them. Tally is assigned to one, I'm assigned to one, Lauren's assigned to one, and Sanjeev, I think, and Laura. So 5 executives have been assigned. And then we're also going to each H&H site and really working with them because they're very invested because they do not want to see an uptick in the uninsured population. And that is what they're seeing right now. So we are being very sensitive to that.
Thank you.
I'm intrigued. What do you all do when you go to the providers in question? I love the idea. What do you do?
I'll give you an example for my account. So the retention there was lower than our company average. So it starts with, well, what are you doing with other MCOs that we're not doing? We identified that for my account, they had 13 different locations, and we did not have consistent presence of our sales team who do sales and research in each of the locations. And if somebody was out, sick, PTO, etc., we were not proactively communicating. Versus some of the other MCOs have, had a consistent presence. The other small trivial thing is having a known contact list. So for this location, here's your person, right? We're there on Wednesdays, but if somebody needs to restart on Monday, right? Here's your person, and here's the backup, and here's the manager. So not rocket science, but nevertheless, like just a small operational adjustments. So we fixed it. So now each of the 13 locations has at least one day, depending on how busy and how big they are, but at least one day, the same day of the week that they know somebody from MetroPlus will be there to recertify, so they can tell their patients this is the day. And if not, if they're there on a different day, they have now an updated list of their reps that they can contact personally, not a call center, personally, and they will take care of it. So that's an example.
And another example would be members that are newly assigned or newly attached to the facility, trying to get them to see a PCP right away. Because if they have a PCP they're attached to, more willingly that they're going to stay with you. It causes a sickness. And then also another strategy is the facilities that have CAC, which is your facilitated enrollments. They help with the enrollments. And so when they are enrolling patients and the patient doesn't have a document, we go ahead and enroll them temporarily, but it's important for them to get the document. And so we ask them to remind the CACs to put it on the tracker to get that patient to submit the documents to help us retain those members. And so several different strategies that we roll out to all the facilities.
Yeah, no, it sounds great. Very creative. What is your goal in terms of disenrollment percentage or recertification performance? What's the goal overall?
I mean,
For
ideally, we would want to be at 85%. How realistic it is in the current environment, it's probably a little overly ambitious in the current environment because it is objectively harder to recertify. There is more scrutiny over the documents. There is more rigidness around which documents are being accepted. Obviously, the eligibility criteria in general are changing. And then there is just, the not so tangible but real sentiment, right, of what's going to happen if I will use a government sponsored. So all of that together, I think probably makes 85 a wishful thinking. We will be happy if we were somewhere between 81 and 83.
okay, got it. And is that what's in the budget, the 81 to 83 assumption in terms of recertification and therefore membership?
85. Okay, the answer is a no. The answer was our optimistic 85. So that would
Okay.
explain why we are behind. We certainly, these years have been packed with changes, so we're learning. Certainly there will be adjustments for our forecast, but those are very good questions because yes, that shows the delta that we're experiencing.
How often do you reforecast the budget?
We look at it every quarter and recast it with new information, right? When we are actually doing our original, when we are redoing our original forecast, when we have our original forecast out of the gate, we are doing that in the blind. We don't have Medicaid rates for the state fiscal year coming up. So when they become available, we do recast on the quarter. And 2026, largely, for work requirements and churn, that's expected for 2027. So while we knew the base would be shrinking at the time of the forecast, that's what led us to our stable assumption on research. But next year we'll have a lot more considerations and assumptions that we will be transparent with.
There have been lots of changes.
So
I think the need to reforecast is just expect. I mean, it's gonna happen. I mean, you can't. Yeah.
Oh yeah.
So it was more just I'm more curious as to how these all tie in together and how one reforecast. The expectation is always going to be there that you're going. I mean, especially in this environment, as you were saying, Talia.
So what I want to share briefly is what adjustments we're introducing. This is all known. Obviously, we're calling, texting, mailing, emailing. Obviously, we do all of that. But this is what we're adding. And I believe that all of this is in progress at this point. So number one is obviously we have prioritization in our outreach for retention. We always try to target people with higher risk, with lower chance to recertify, with more complexity, et cetera. Obviously, there are better and more accurate ways to do it. And there are additional data sources that we do not have, such as consumer behavior. For example, you can purchase consumer behavior saying these people are more likely to respond to a text, and those people are more likely to respond to written communication, et cetera. But there are other data sources that are available that third parties purchase. We just signed a contract with a vendor who offers those additional data sources and does then the analytics, takes our data sources, the ones that they purchase, combine and create essentially a priority list. The contract is signed. We're working on implementation to be smarter on how we prioritize the outreach. We constantly look to see why people are leaving us out of their own volition. So this is the voluntary disenrollment. Number one reason is network. So we have been putting a lot of effort into our network. We had pretty significant wins this year. We have now Tribeca Pediatrics, which we know was a big deal for individuals with younger kids. We brought advanced care physicians back into the network after a long hiatus with them. And then we brought a bunch of behavioral health, telemedicine offers. We have midlife and menopause vendor for women, obviously a topic that has been neglected for centuries, actually, not decades, and that at long last is getting some appropriate attention. So we have been really enhancing our network in a meaningful way, and we have specific goals each year. So far, we're on target, progressing towards our network expansion. Leveraging other departments, similarly to quality, retention is everybody's business, not just the retention or sales department. So we have now direct referrals from case management, right? If you're talking to a member, you're already connecting with them. It makes sense that if they also need to be recertified, A, that you'll know about it, so it appears in front of you, and B, that you will have a direct contact into retention and you will not be put into a queue. So those type of internal referrals are now in place. Lila mentioned brute force. That also is helpful. We are adding more than a dozen new temps just to help us with massive outreach to save anybody that we can potentially save. We also see very significantly lower retention rates in subpopulations in the HIV positive and in the SMI population. So what we've done is adding certified enrollers to sit in those departments. So instead of doing retention for everyone, we thought, well, these people are qualified, trained, and have specific attributes. This is why they were hired into those departments to work with the subpopulations. So why would we think that for lack of a better word, our cookie cutter approach would work for them? That doesn't make sense, right? We say you need a specialized department. to deal with you. But when it comes to retention, just go into the general queue. So that doesn't make sense anymore. So now we are bringing the research function into those departments for those people who know better how to deal with special populations. And then finally, we certainly identified areas for improvement in workforce management. We have tools across the company. They're being utilized in other departments quite effectively, where we can be much more nimble in managing the workload. I mentioned that we have some fluctuations because of volume. It's all known. None of that is a surprise. We know how many people we need to recertify every month. But even throughout the day, there are fluctuations in volume and in need. We have tools in other places where we manage this hour to hour fluctuation that we're working now with analytics to bring into the retention department and just really squeeze all of the juice that already exists, not just add more and more, but squeeze more efficiency out of the resources that we have.
And I'm just going to add, Juliana, because you're relatively new, we also have like a ZocDoc experience where we're allowing our members to make an appointment at their own time to sit with our recertification team, and we'll go ahead and schedule it, and we'll sit down and walk them through. So it could be via a phone call or a video, but we'll show them how to recertify.
That's great.
And that's it.
Hello, good afternoon. My name is Tomasz, and I'm pleased to present an update on Project Edge. Now, first and foremost, I want to answer the question of why we're doing this, because we have some new faces around the room, and it's a question that even we get from our team today. We're replacing our core platforms for a couple of key reasons. First one is the easiest. We have to. Our TPA, who currently administers our platforms, is no longer supporting the product and is terminating operations at the end of 27. So one way, shape, or form, we have to migrate to a new solution set in that time frame. Two is, we're the last client that is on this current solution, and that creates a number of challenges for us. As you've already heard earlier, there's a number of regulatory changes in the environment, a number of new mandates. Since we are the only client, only user of this platform, we have to absorb all of the cost of implementing compliance with the new mandates. And as such, it is much more expensive for us to maintain the current solution set than it would be to use a shared platform like the one we're moving to with Health Rules Payer and Guiding Care. Now, we've been live for over 6 months using this tool set for our HIV SNP population, and I want to share with you a few updates from the team of the outcomes that we've seen. First, from the operational teams, and I found this example resonated with me, we compared it to rotary phones, to corded phones, to the cell phones that we have in our pockets today. To look at a fee associated with a payment to a provider today, our associates go through the following key sequence. F12, Shift F8, tab, tab, tab. Now, that is intuitive to some. It was not intuitive to me. In the new system, they click the fees button in the payment menu. So it's relatively straightforward. They have a modern UI. Now, again, comparing keystrokes to UI is experience, but what it does, it lets the associates focus on the outcomes rather than the mechanics of how do I navigate the system and get things paid. Another advantage of the system is that all of the business rules and the how is exposed directly in the system. So when we're performing an adjustment, as an example, the associates can see exactly the logic that went through and preview the results in real time, rather than requiring an overnight batch and assumptions on how it will process after the effect. So it really is bringing us into the new century of processing. Now, on the medical management side, we have a number of advantages as well. Dr. Shah spoke during our town hall. As one example he cited was our advanced care management activities and reporting thereof. Our team hasn't changed. What we do hasn't changed, but the system in which we document has. Before we made a switch, we reported on average about 7,000 advanced care management interactions every quarter. Again, these were calls, be it coaching, navigation, outreach to our members. After we made the switch, because of the change in the granularity at which we capture documentation, we reported 12,000 advanced care management activities last quarter under a new platform. So we're having a meaningful impact both on the core claims processing side as well as on the and care management side using the new platforms that we have. Now, if you go to the next slide, the important news for today and why I'm speaking is because we've made a challenging decision to delay our go live of Wave 2. We made our delay to the go live of Wave 2 for three key reasons. First and foremost, Wave 2 for us scales the volume on the platform 100-fold. Therefore, our ability to accept errors or manual workarounds is much, much, much lower than it was during the first wave. And we did not have the confidence 90 days out away from the go live that we would not have to incur manual workarounds. The second reason is we don't have all of the functionality that is required for us to process at scale yet. We had a couple enhancements, a couple features. I'm going to use the word enhancement. A couple features tied to key functionality required to process the volume, like mass claim adjustments, that is not ready, and it will not be ready until July. And we want to make sure that it's of topmost quality and it's ready before we go live. The third reason is that our overall internal testing efforts have been delayed when we started testing. They've been delayed because we had environment stability issues as we were standing up the environments and the new code base. So as such, we incurred a penalty when we started out testing. Again, we've made strides and progress since. We began to catch up, but we still have a schedule deficit that we're working on making up. And as such, we made the challenging decision to push it out to Q4. Now, few items to note. This is not easy, right? We have hundreds of team members working on this migration. We have all our teams driving this day in and day out, doing everything possible to move our membership to this new platform with the quality that is necessary for us to effectively serve our members and providers. We can go to the next slide. Again, what our roadmap looks like now, and I think this is important, we're live on the first wave. We've pushed our second wave from an end of August go live, Labor Day go live, to Q4. Next go live that we have planned is our BPaaS go live. Again, we have a partner who's going to administer our MA and QHP lines of business on our behalf, and that is targeted to go live in January. Now, that January go live has a very high risk profile. It has a high risk profile for a couple of main reasons. The first one is that by shifting Wave 2 down the line, we now run into contention in a couple areas of the program that we need to solve for. We began solving for this, but I'll give you one example. We may have to test for two different lines of business in the same environment at the same time, and we've got to figure out how to coordinate that across multiple parties and multiple partners and multiple lines of business. So we have a couple items to solve for to enable for that January go live. And we also have to complete the full set of configuration in time for us to test it thoroughly. So those are both of the items that are on our critical path, and we'll have more information on our Wave 2 go live and our risk profile and our testing results the next time we meet as a group. And after that, our final go live is in Q3 of 27, and that is our remaining book of business. Now, let me give you a few, let's go to the next slide, please. Again, I think this is a summary. We are live and we're making great progress towards being ready and being done. Go to the next slide, please. Just wanted to share a few numbers, because when you measure a technology and implementation number, anchoring in data is important. Usually when you push out a program like this, it's because you have net new requirements and things have changed. While things have changed, every metric that we have around requirement stability is that our requirements are pretty good. Our churn rate is pretty small, and mostly it's a result of changes introduced by our regulators. So all in all, our requirements and scope, we did pretty well. Build completion, I think I shared earlier that some of the features that we need to operate at scale will not be ready until July, and it's one of the drivers for our delay. Testing, we started off slow. We had a very high defect rate in the beginning as we were facing environment issues. But as we continue to make progress, that has stabilized and we are catching up. Again, build quality early on, environment issues, defect rates have since decreased significantly from what you see on this slide. So all in all, I think as a program, we are making good progress towards our revised roadmap, and we made the decision to push it for the right reason. We have to go live with a product that meets the quality expectations of our members and providers and team members, of course. If we can go to the next slide. I think if we skip through these slides, this is status a little bit, talk about risks and challenges. The few items of note, we have a fixed timeline. I shared earlier that we must be fully live on these new platforms by the end of 27. Our current roadmap permits us to do so, but we may have to make trade-offs down the line of what minimal viable product looks like to enable that. We talked about, this is history, we made some changes in the program structure and the vendor partners we had supporting us over the last year. I think we're stronger as a result, but I don't want to minimize that every change that we make has an impact on how we move as a program. And then again, while so far we've been able to absorb the cost of extensions in our budget and our contingency plans, as the program moves on, we will need to continue to look at these metrics to ensure that we have the support that we needed to successfully deliver. And as of today, we still do. As of today, we do. Challenges, again, I don't want to just celebrate the successes. I want to call out that when we went live with Wave 1, we achieved our main objective, which was to provide a seamless experience to our members and providers. But we did have to implement a series of manual processes and workarounds to enable it. And I want to, again, call out all of the teams that have continued to support and operate and make that a success, but want to repeat that that is not an option for future waves. Simply the volume does not permit us to do it. So just wanted to highlight key risks and challenges. Any questions? No questions. We'll go to student.
Hi, everyone. Good afternoon. Apologies for not being there in person. I did not realize that I would be presenting today, so I apologize for being remote. Sudha Chatterjee, nice to meet you, Juliana, and I don't know who else is in the room who I haven't met yet, but nice to meet all of you. I'm going to be talking about our gold enhancement. So earlier and throughout this meeting, we've been discussing the headwinds, right? We know that there are headwinds that are going to be facing. They're significant, that are going to pose challenges that we need to be able to bring ourselves up from. Gold is obviously critical to our growth and future. Remaining competitive truly is something that we need to continue to push forward with. This is key to our growth and stability. The predictable revenue and retention, really driving those pieces forward, is going to enable us to face those headwinds that we just talked through. Next slide, please. Thank you. So one of the biggest things that we are doing is continuously focusing on improving gold so that it is competitive in the marketplace. So focusing on cost, access, and support is something that we are very focused on. The product team has worked very hard to ensure that those value propositions that our members really need to stay retained are addressed. So we talked about network earlier. A lot of the pieces that we're talking about are lower costs. So things like zero copay urgent care. That is huge, right? So many folks, many gold members, many of us utilize urgent care as a way to get PCP care. So eliminating the copay is a significant change, one that we need to make sure that we champion for members. Other things that improving costs are lower pharmacy rider fees for individuals and families, improving access to low-cost drugs, right? We've expanded that list of drugs where there's low-cost access. Expanding maternal support, right? That's a big piece. We know that our maternal population does like to utilize doulas. So paying attention to that and driving the ability for them to have covered doula visits during their pregnancies, so up to 8. Talking about enhanced coverage, so podiatry visits up to 8, again, annually, helping to support our diabetic patients, and truly focusing on whole person care. So we do have the rewards program I'm going to talk about in a little bit that we can utilize to focus on preventative and supportive services. Next slide. So this is the rewards program. So one of the biggest pieces that we do need to champion is that we are the only plan that provides our members with this level of rewards program, and it's substantial. It's not little. So we want to make sure that our members are not only utilizing and understanding that this is available, but understand that we truly are supporting their wellness. We want them to go to the gym. We want them to utilize whatever it is. And so that piece is something we're building into the member experience as we talk through the value proposition. Next slide, please. Oops. Next slide. Thank you.
Sudha, curious about the fact that you raised on that slide, and I think I heard it earlier from someone else. It sounds almost as if you're saying we're offering you these wonderful things, use it, which would suggest to me that perhaps it's not as valuable to the member. And so that then raises the question for me is how you know that these are benefits that matter to the members.
Yeah, and that's a great question. What we're finding is that our members do not know how to register for the capability to actually utilize and redeem. So I think the process is a little bit too, I won't say cumbersome, but it's a step process. It's almost a 3-step process. So one of the things that we want to do is not only educate members, but try to make it less burdensome. So some of the discussions that I've been having is related to my previous experience in previous health plans where we would auto redeem on behalf of our members and send them a gift card. Not saying that we can do that here, but I am looking to have those discussions with our internal teams to say, how can we make it easier so that our members, we can delight them, right? How amazing would it be to get a gift card in the mail, right? Or better yet, into your Apple Pay or whatever the mechanism is that we look at with our vendor. These are things that I think we need to look at. Why are our members leaving thousands of dollars on the table? Why are they not utilizing the gym? If they have a Peloton at home or if they have a gym app that they use for Pilates, get it reimbursed. So I think part of this is we communicate so much to our members. Are we communicating in the right way? Meaning that are the messages that we really want to resonate with them popping out? And how do we streamline those efforts? That's key. And that's part of the reason why I'm here. I joined about a month ago and I came over from Health First. And so there are pieces that I'm bringing from there too. And I also worked in the Blues plans, and they also had challenges with their rewards program. One of the challenges is making sure that at the point of sale, right, if a member takes a gift card and goes to use it in a pharmacy, that it's recognized and everything that they're utilizing it for, like the bandages, is, the SKU is allowed, right? So there's all these little challenges that I think are prohibiting members from utilizing it. But I hear you exactly what you're saying.
Juliana, I think you're bringing a good point, because is this really a selling point, right? I think that's what you're saying. Even if it were easy, is this a real differentiator? And I don't know that we know the answer to that, actually. I think that's a really good point, and it should be a follow-up for us to survey gold members or potential gold members and say, is this a selling point for you or not? I think that's a really, really good point. I will tell you, we do know that 54% of the gold population registered. So it's actually, we say only, but I think, wow, I don't think it's an only. The registration percentage is quite high, which potentially supporting what Sudha is saying. There's interest. 54% is significant. I don't remember at the top of my head what the redemption rate was for those 54%. Obviously, it's a fraction. So it seems like there's interest by that percentage point, but is it really? Is anyone going to make a choice based on that? We don't think so. But I think we should ask, point blank, just for just that question. But I think the other one is sometimes, if we surprise them in a good way, the way Suda just mentioned, and suddenly they have a card appearing with money, is this now a delighter that will motivate them to tell others, right? One of the issues that we're struggling with is the other plan that has the majority of lives has been around for 80 years, and it's almost a default enrollment, at least in some of the agencies in some of the areas. And when somebody asks their colleague, well, what did you choose? They will share. So is this an opportunity to, and I know it's an overused word, but I'll still use it, to delight a member to a point that they'll say, you will not believe what I just got from a gold membership. But you're right. We need to be more critical, because to offer a bunch of good things does not necessarily mean that we will get better results, and we should be critical of that.
What's the competitor health plan?
The combo of Emblem United.
I see.
But one of the areas where we can get a lot of feedback will be from the MLC and the unions.
That's a good yeah.
Because they know what their members want and what they use, because they have their supplemental welfare fund benefits. And, we have to be careful in dealing with them and how we talk to them, but it's always going to be a great spot to get feedback on what members want through their representation.
Absolutely, yes. Back to you, Suda.
Thank you. Do we have time to keep going or no?
Really quick. No. You have 1 minute. How's that?
Okay. So how about this? In that 1 minute, I will just talk about the fact that we're looking very focused. We're very focused on our level of support that we're offering members also when they call in, looking to have more proactive customer service so that we ward off their questions and anticipate their questions. So the way that I like to describe this is that we really want to hug our gold members so that they feel that they can trust us, right? And again, delighting members, trusting member, or getting members to trust us, and the loyalty, those are all kind of zinger words. How do you make that happen? That's a piece that we're really working on. Our signature concierge service that we're going to raise is going to be, and I believe you talked about that earlier, is going to be another mechanism that we're going to educate our members. We're going to really usher them through the process of not only onboarding, but utilizing their benefits and all the valuable assets that we have for them to utilize. So with that, I will say thank you.
Okay, we have one last thing to round out the board meeting today. So I would just like to, on behalf of the board and PLP, I'd like to give Talia her 10-year award. I have a quick highlight reel that I have put together from your finance lady. So Talia became the CEO in 2019, and so just for some scale, our net worth has grown by 127% since you have been our CEO. We have scaled our enrollment from 515,000 lives to over 760,000 at our peak. We have competitive products, not only Gold, but Medicare, top offering. We also enhanced our workforce. We have a talent and progress. We're a trusted brand. We're on the map. And we serve our members with dignity and efficiency every day. We keep experience on our forefront. We brought behavioral health in-house. We house homeless members every year. And then for our most fragile members, we even have an in lieu of food benefit. And how can I not ignore Health Edge? Health Edge keeping us alive and killing us at the same time. So I hope, we have many more years, another 10, and you get a candy dish with your ministers. Thank you. Wow.
There's on the Health Edge. There's been, from my understanding, 3 stops and starts to modernizing the system, and you actually had the guts to say,
That's right.
let's get it done.
Or I didn't have the choice.
Wow.
Wow. Thank you. You actually really caught me by surprise. I was here the whole time. I made no connection whatsoever. So thank you. It's a privilege and a pain in the butt. First of all, thank you to all of you, my team, amazing team, who does all the work. And obviously to incredible board, our chair, our standing chair, and all of the board members, and now with Juliana, and the amazing knowledge coming from Kathy and Kara and Valencia. Thank you to all of you. I mean, there's a reason why we have 1,600 people here, because it really takes a village to do this work, as you can tell from our presentation. So thank you for this really, really unexpected and
I'm only sorry I couldn't be there today. Of course, it would be the day, but you know, I think the world of Italia, and so celebrate your 10 years and the next 10 to come at least.
Thank you, Sally. I really appreciate it.
Hold off a surprise. Way to go, guys.
Thank you, sir.
All right, with that, everybody, I'll adjourn the meeting. Thank you very much.
Thank you. Bye-bye.
Thank you. Bye-bye, everybody.
Bye.